Good afternoon, everybody, from ICI 2020 in Tel Aviv, Israel. I'm delighted to open this satellite symposium entitled Comisural Alignment and Coronary Access in TAVI. This is the TAVI session, and we have the privilege to transmit live from Copenhagen, Denmark. The group of Professor Lars Sondergaard and Professor Ola de Baker, they are going to perform a very interesting case that we are going to watch. And with me on the panel, I have the pleasure to introduce Professor Sabine Bleidefer from Germany and Dr. Ignacio Amat Santos from Spain. Both are top experts in the field of valvular and structural heart interventions. And they are going to participate with me on the panel by commenting and asking questions the operators. So I think, hello Sabine and hello Ignacio, and I think that without further ado, we are going to move ahead and ask Professor Thundergaard, Lars, can you join us and present to us what's your plan and the case of today?
Yeah, thank you, Ran, and thank you for the invitation to do this live transmission from Copenhagen to ICI. So I'm here with my colleague, as you said, Ole de Backer, and our fellow from Hong Kong, Ivan Wong. So let's see on the case. Can we have the slides up on the screen, please? So can we have the first slide, please? So we're going to do a TAVI procedure with the Acurate Neo 2 system. Next slide. This is a relatively young lady, 72 years of age, normal body size. She got a history of lymphoma and also have both chemotherapy and chest radiation. She was referred to us due to severe aortic stenosis and she have symptoms, functions class 2. Next slide, please. Echocardiography actually confirmed there was a severe aortic stenosis with an opening area of 0.9 square centimeter, peak gradient 137 millimeter mercury, and a very high mean gradient of 90 millimeter mercury. Preserved left ventricular ejection fraction. She also have a coronary artery disease with a borderline stenosis on the left circumflex, but that was done FFR, and it did not need to be addressed at this setting. But of course, we need to keep that in mind, that we need future access to these coronaries. She's in sinus ridden, no conductance abnormality, normal hemoglobin, renal function is normal, STS score is 1.8, so a low STS score, but remember she had chest radiation. Next slide, please. CT scan revealed that she have a perimeter-derived annulus of 21 millimeter. The same was actually both in systole and diastole. Next slide, please. Coronary height was sufficient, around 14 millimeter both from the left main and from the right coronary artery. Next slide, please. Sinus valsalva was really right between 28 and 31, so we don't foresee any issues with the coronaries here. There was severe leaflet calcification in a tricuspid aortic valve. Next slide. The anatomy was quite favorable. It was almost a vertical aorta. ST junction had some calcification, but I don't foresee that we go up to that size balloon if you want to do a post-dilatation. Remember, the annulus size was 21. Next slide. Aortic arch was also favorable for using cerebral embolic protection device with the Sentinel. Next slide. And access vessels was good. Not a lot of tortuosity, not a lot of calcium, and the minimum diameter on the right femoral artery was 7 millimeter. Next slide. So the plan is that patient is in fully local anesthesia. She's awake. We're going to use a MANTA closing device. we're going to use a 14 French expandable ice sleeve introducer, pre-dilatation with a 20 millimeter balloon. We're going to implant an Acurate Neo 2 valve, small size. And as I said, we're going to use the Sentinel cerebral embolic protection device. We'll come back with a few more slides on commissural alignment when we come to that stage of it. So first, Ole, let's just quickly show what we have done before we went live.
Well, not that much yet. We have just placed 2 6 French sheets in both common femoral arteries, and then 1 7 French in the venous, and I have a radial access.
Yeah.
So that's all.
Okay.
So I think the first thing we do now, because we're going to use Manta, is to do the measurements, how deep the vessel is from the skin to the artery.
So for those of you who have not used the Manta, it's like an angioseal device, of course bigger. The only thing you need to do up front is, as Ole was saying, to measure the distance between the skin and the common femoral artery. So now we just introduce a standard catheter into the descending aorta. We're going to introduce a stiff guide wire. This is a super stiff Amplatz guide wire. And then we remove the catheter, and we also remove the 6 French sheet from the groin. And then we have this 8 French ruler here. You see there's a measuring scale on it. So we can actually measure what is the distance between the artery and the skin. And we're going to recall that number to after the procedure when we're going to deploy the Manta device for closure. So as you see, Ole is going to introduce it. And
are you going to add 1 to the number?
Yeah, we're probably going to add 2 centimeters to this number. That's our practice.
Even 2.
Yeah. So you see, in a minute, you're going to see that it's going to bleed back. If you look here on the right-hand side of the screen, you see now it's bleeding back and the Ole is coming out. And then he's going to... 5 centimeters. The distance is 5. So we're going to remember that afterwards. So now we can proceed, and we're going to introduce first a 12 French sheet to do some kind of dilatation of the skin and the vessel before we go in with the ice sleeve. And for those of you...
Lars, can you say a few words about device selection? Because I'm not sure that all our audience are familiar with the Neo 2 version of the Acurate.
Yeah, I will do that in a second. First, I want to show here the ice sleeve. So this is an expandable sheet. So it's 14 French here. And it's, as you're going through with the Acurate valve, it's going to expand up to 18 French. And this will, of course, open up for more people who can be treated by a transfemoral approach. And that's you can use this sheet for all 3 sizes of the Acurate Neo valve. So let's just take the 12 French sheet out. And we will introduce the Manta device, the ice sleeve.
You hold the wire.
And again, since it's a low profile, it's often very easy to bring it in.
It goes very smooth.
Yeah. So going up here.
Stiff wire.
Yeah, and then we can take the dilate out, and we can go in with an AL1 catheter.
Professor Sondergaard, may I ask why you chose the other femoral as secondary access?
Why did we choose
the other femoral instead of just radial as secondary access?
Yeah, you can say that. I know quite a few people is not using that. We as a routine is using it, but as a good issue, quite a few people will use the femoral artery, the radial artery instead of the contralateral femoral artery. On the other hand, we use, as you saw before we went live, we use ultrasound guidance. So I would say we don't have that many vascular complications with it. No. But that's a good point. So now we have the big sheet in place. Heparin is given.
Yeah,
Yeah.
it's given now.
So next thing is to introduce the Sentinel device here for cerebral embolic protection here. And again, it's a 6 French sheet inside the device. We have a coronary artery guide wire. This is a BMW wire. And we actually do not use aortic root injection to see where we have the neck vessel. We saw the CT scan before, so knowing what the CT scan was looking like, and also we having the AL1 catheter in the aortic arch to show us where is the outer curve. This is often sufficient to implant it. And as you know
are you using the embolic protection in all your cases or selectively?
We have used it in all cases. Everyone where we can see on the CT scan it's suitable. You know, there's 3 markers. There's a slider 1, there's a knob 2, and a slider 3 here. So there's 2 filters. So by pulling back the first slider here, you see the proximal filter here, which is sitting in the brachiocephalic artery, is coming out. Next, you take the knob here, and as you twist the knob, you'll bend the device up. And let's see, there's a high gradient. You see how it's pushed away.
Yeah.
So we try to steer it up towards the left common carotid artery, which I think we are here. Is that correct? Is it? Now let's see. Maybe it's a subclavian artery.
I think they're closer.
Yeah. So we come a little bit. We come back again here.
Go a little bit deeper and again first. Wait. Oh, push.
Yeah.
Yeah, and rotate a little bit more.
Yeah, like this. Yeah, that's it.
That's better.
Wonderful.
Yeah.
Yeah. Very nice.
Pull it up here, and then we deploy the distal filter.
Yeah, that's it.
So you see, it's actually quite easy to bring it in. It doesn't add more than a minute or 2 to the procedure. So next,
give me a picture afterwards.
yeah, we can have a pigtail. So next we're going to cross the valve. Remember again, this patient had a really high gradient. There was a mean gradient of 90 millimeter mercury. So hopefully it's not going to cause too much difficult to cross it. So while Olis will try to cross it, I can come back to your question, Ron. Why choose an Acurate Neo2 valve in this position? First of all, there's at least 2 main difference between the classic Acurate Neo and the new Acurate Neo2 valve. First of all, it got an enhanced sealing skirt, which is going to mitigate the degree of paravalvular leak. And the experience we have so far with this device is really promising. Let's see how it's going to perform in this very challenging anatomy, heavily calcified aortic valve. The second feature is that on the shaft on the delivery system, there is an enhanced radiopac marker, which can be used to show how deep you need to be during valve implantation. So that marker needs to be at the annulus position. With the first generation Acurate, it could sometimes be a little bit difficult to see where exactly you should put your valve, but that's certainly easier now with the new system here. So why choose
So
an
with the central marker, you say?
Yeah, you will see it when we introduce the system here. So why choose the Acurate valve here? Again, this is a patient of a younger age, a patient which we expected having a longer life expectancy. And I think you have to have an even higher level of ambition when you do TAVI procedure in these patients. You need to think about durability. How do you get a good durability? And I think one of the factors which is going to impact the durability is that you have a large opening area and a low gradient. And I think a self-expanding technology with a supinal position of the leaflets will probably offer you that. Second, it's also going to have, because the valve stent frame is not flared in the left ventricular outflow tract, it has less interaction with the conduction system, and thereby also a lower rate of pacemaker. You saw this lady had borderline coronary artery disease. She's 72 years of age. So there's would say a high possibility that we in the future need to re-access these coronary arteries. And I think that's important to think when you both you choose your valve, but also how you implant it. So with the Acurate valve, where you have large stent cells, it's often easier to access the coronary arteries, and particularly if you can make commissural alignment of this valve, which I hope we can show you here how to do it quite easy with this valve. So I think there's quite a few features with this valve, which is making it attractive to treat this kind of patient with it.
Sure, very good points. Any comments on valve selection from our panelists, Sabine or Ignacio?
Yes, of course. I think it's crucial in patients like this one with a small annuli, the selection of supraannular valves for the durability of the device. We know this very well in the south of Europe because we have a higher proportion of small annuli. And I think it's a very nice selected case for Acurate Neo 2. Very calcified, so we will check how it responds to the new sealing of the device. And I think the challenge is very interesting for the audience.
And as expected, I mean, this is, even though we say 0.9, I think it maybe even be smaller, this opening area with this high gradient. And you can see Ole is struggling a little bit to get in. We tried first with a standard guide wire, straight guide wire, and now changing to a Terumo guide wire to see whether that's going to facilitate crossing of this calcified aortic valve.
Yeah, we see very clearly the calcium silhouette of the aortic leaflets, and I presume that you are going to predilate in this case and using this specific valve.
Yeah, we actually predilate in most of the cases with the Acurate. This is also in the IFU. So that's certainly something we're going to do in this specific case with a high gradient. People talking about radial force. Does one valve have better radial force than another valve? I think actually most of these self-expanding valves have the same radial force, but there's a difference in the opening force. How well does the valve actually coming out of the delivery catheter and expand up? And I think some of these valves, as the Acurate valve, has a lower opening force than some, let's say, the Evolut valve. And to compensate for that, you have to do more pre-dilatation than with the Evolut valve. The benefit is that you get a system which is much more flexible. So if you have tortuous anatomy, acute angulation of the aortic arch, horizontal aorta, that's going to be beneficial to have a system which is more flexible.
Yeah, we clearly see it's a very challenging anatomy to cross. Obviously you should take your time. And maybe we can also discuss the issue of coronary access. You mentioned the rationale of choosing this specific valve, the Acurate Neo 2, because it allows future coronary access. I think that this has been the impression of many operators that have used this valve platform, and this is a very important consideration, especially when you're dealing with 72-year-old patients with life expectancy of many, many years ahead. So obviously the future access for the coronary is a very important consideration here.
And I actually, if I have the next slide while Ole is trying to cross it, I can try to show you what we mean about commissural alignment. So you know there has been this move to use the Cusp Overlap view, which means that you bring the C-arm during implantation towards an REO caudal projection, where you have the right and the left coronary cusp overlapped. In that projection, you have elongation of the left ventricular output tract. Yeah. And you see here on the middle part of the screen, this is a traditional coplanar view where you have the three cusps aligned and the right in the middle. But on the left-hand side, you see you have the cusp
Keep them on.
overlap view. And if you look here, you look at the eye, this is the C-arm. So it looks like the right and left is overlapped. But at the same time, you know, in this position, you have the commissure between those two cusps pointing towards the right-hand side of the screen. So if you, in this projection with the cusp overlap, can position one of the posts on the far right of your fluoro screen, you know you're going to have commissural alignment. So this is what we're going to do. And of course, it also means that you need to be able to identify the posts on the transcatheter heart valve. And as we're hopefully going to show you in a minute, with the Acurate valve, it's actually quite easy to see where the posts are located. So if you can bring one of the posts to the far right-hand side of the screen in a cusp overlap view, you know you're going to have commissural alignment. But let's go back to fluoro. Ole struggled to get across this calcified valve, but it's now in place. And what we're going to do now is to change to a pigtail catheter, as most people will do, first of all, to have some hemodynamic assessment, not as much for what is a gradient, because we know it's a high gradient, but we're going to measure the diastolic pressure in the aorta and end-diastolic pressure in the LV, and we're going to compare these numbers to what we're going to measure after the procedure as part of the assessment of paravalvular leak. So if you can see hemodynamic on the screen, please. So you see there's a high gradient here. We can record it here. Like, So we have a gradient of 73 millimeter mercury. But more important, we got a diastolic pressure of 56 and an end diastolic pressure in the LV of 25. So we're going to record those two numbers. Next, I think we're ready for a pre-dilatation.
Maybe for the pacing, we can also put that ready.
Yeah, we can do that. So we're going to do LV pacing. So that means that we're not going to introduce a pace lead to the right ventricle, but we're going to pace on the guide wire, the stiff guide wire. So you have one crocodile lead here on the guide wire itself, and another one in the groin. We used to have a needle in the groin to attach it, but we actually found out that you actually have better contact if you just use this venous support here. You have a short guide wire and you attach the other one here, so you don't need to put a needle in. For the stiff wire, we, as a routine use, the Safari wire from Boston Scientific. It's a stiff wire which gives you good support, and also it's a pre-shaped curved. And I think in this case we're going to use the extra small curve, And for the pre-dilatation, we will use the true balloon from Bart, a 20 millimeter balloon, which I think is close to the minor axis of the aortic valve. Yeah, I can attach this one. So I see I have one crocodile lead. Connects it here to the short guide wire in the left femoral vein. and at least what I think is nice with the true balloon is that it's extremely fast to inflate and deflate, and also it will bring you to the target diameter. So since this is a 20 millimeter balloon, it will take you to 20. You cannot really overinflate it and going up to a higher diameter.
You hold wider.
So I understand you intend. Do you intend to pace only during the valvuloplasty or also during the valve implantation?
Only during the valvuloplasty. And of course, if that should work, pacing on the pace lead, you need to have some isolation on the guide wire. So if, let's say, the patient will develop third-degree AV block, you cannot remove the system. You need to put a RV pace lead in before you take it out, because if there's nothing on the guide wire, you can't really pace. So should we come a little bit higher? Yeah. Like so we can start pacing 180, Barbara. Start pacing. Start pacing. Try to pace 220. I think we need a little bit faster rate here to have a stable position. Yeah, start pacing. That's better.
We should do it again.
So we do it once again. Stop pacing.
Yeah,
Go to 250.
we don't get the pressure very down in a way.
So maybe we have to go a little bit deeper once again. Yeah, let's go up to 250. I mean, it's a good ventricle there. Start pacing.
Yeah,
I think that was better. Stop
that
pacing.
was good.
Now you had it. Yeah.
Yep.
Yeah. So again, we have to look at the ECG. There's no AV block, so we can take it off. Otherwise, you should, as I said before, wait until you have an RV lead in for pacing.
Wide. Yep. Yep. Okay.
So we get the valve. It's coming here. Just wind it back even. So right now.
Yeah.
So again, from outside here, there's not a lot of difference from the previously Acurate valve. So, but again, there's an enhanced sealing skirt and also a more radiopack marker for where you should be at the annulus level. But you're going to see that when we introduce it here. So
I believe the ceiling is a bit shorter, no?
the sealing skirt, I'm not sure
Yeah,
it's
it's a
shorter.
bit shorter.
Yeah.
I think so.
Yeah. So now it's going in, and as I said, all three Acurate sizes going into the same size ICI 14 French here. And of course you need to give a little bit pressure because the sheet needs to expand as the delivery catheter is traveling through this sheet here. And again, it's a very flexible system here. You see when it's coming up, it'll take the aortic arch very nicely. You can follow you up here. Ole.
Yeah.
Yeah.
All right. Hold the wire.
So you see it makes a small bend or even sometimes even a kink to go around. So it's it will take this tortuous anatomy very well. And here, now we're going to this cusp overlap view. Again, right and left cusp is overlapped, and in this, it's RAO 15, caudal 20. And as I said before, in this projection, we know that we have the commissure between the right and the left cusp on the far right-hand side of the screen. So now we need to bring one of the posts to that position, to the far right. And if you look careful on this, on the stent frame, you see on the left-hand side there's a small free stent strut. That's where the posts are. That's three of those. So what Ole is doing now is he's going a little bit up and down with the system, and he's doing some rotation on the delivery catheter to free one on the right-hand side. You see that? On the right-hand side of the screen, you see one free stent strut. Now it came back again. Yeah.
Yeah, we see that.
Like this.
Yeah.
So you probably have to go a little bit back again. So, yeah.
I'll have to go a little bit back.
Yeah.
This pigtail is also a bit annoying. Yeah. Okay. Let's go clock.
Like this.
Yeah, like this.
I'll keep that rotation
Keep
here.
that rotation.
And then you see this radiopack marker here on.
Yeah,
Oh, we
changed
changed again. There's a lot of talk on this. Maybe I'll go a little bit the opposite way, Ole.
Yeah.
Like this. Yeah.
Yeah, that's better.
The radio pack marker was added to the
Yeah, exactly. So that
system.
should be on the annulus level. And you see the free stent strut on the right-hand side of the screen, indicating that we have commissural alignment. So next is just to do an aortic root injection to make sure that we actually
Maybe it's a tiny bit too deep.
push a little bit on the wire here.
Yeah.
Yeah,
Okay, I'll give contrast.
yeah.
Okay, we're actually
Yeah,
a bit
pixel is
too
a little.
high.
Yeah, so you can.
That big,
not
I
sure.
don't think it's going to be possible to bring it all the way down.
So let's peek the angiogram here. Yeah, just stay here. I think you are in the right position.
It's
Yes.
a bit too deep, I would
I
say.
can push you 1 millimeter up on the wire, like this. You keep the wire tension here.
Wait, we came up.
So the question was for the deployment, are you going to stay in this
Yeah, we're going to
commissural
stay here.
alignment
Okay, I
position?
think this is good.
Yeah, you want to go a little bit deeper?
No, I'll push it.
So I'll go on wheel number 1. It's a top-down deployment, so the upper crown is coming out, and you see
The upper
now.
crown are opening
Yeah,
nicely.
Give me the freedom to push a little extra.
yeah, and do an injection.
Do an injection. Okay, we're too high still, so I'll push more. Okay, this is maybe it.
This is a
I
crucial
think that's fine.
step
Yeah,
for
I'll
the
take the split
procedure.
out. Ready?
Yeah,
Go
quick.
fast.
Yeah,
Yeah, quick. Yeah, very good.
nice,
Yeah.
very nice.
Stent holder moved forward, so that's also
Yeah.
promising. Yeah, all right.
So now we need to make sure that we're coming out here. We can just
And we
demag
have-
once more
we
so we
have
can see the
Comisural
guide wire.
alignment
Yeah,
also.
yeah. And so we'll do a little bit of rotation to have the stent holder coming nicely out of the.
Yeah, let's do this careful. Yeah, it's getting into the frame. Yeah. Yes.
Okay,
Now the
coming
nose
back.
cone still.
I pull the wire back here to try to centralize the nose cone. We'll go a little bit forward. Ole.
Yeah, well, I think I have to go a little bit forward because
Yeah, let's see here.
it's of course also small anatomy, so that doesn't help.
Yeah,
to-
let's try again once to do some rotation. See whether
It's
we
in,
can
it's
bring it in. Yes.
You can come out with a wire now. Yeah. Yeah, come
Yeah,
on.
you are there. Very nice
Alright.
maneuver.
Careful.
And we have a commissural alignment. That's also, you can see that already here.
So now we just do the opposite. Wheel
Yeah.
number 2 to bring the nose cone down to the stent holder, and wheel number 1 to close the capsule here. Like
Yeah.
this, and we can come out and get a pigtail.
And the patient is very stable throughout the course of implantation.
Yeah. We can. You can.
Yeah.
Good.
Okay.
So we
Yes.
get a pigtail.
Yeah, pigtail.
Catheter here.
And after the regular J-wire.
If you look on the stent frame now, you see one post is isolated on the right-hand side of the screen, and the 2 other posts is overlapping on the left-hand side of the screen, which is it should be if you want to have commissural alignment here in this right and left cusp overlap view. But we're going to show you in a minute that it's har vi et venstre konar? Yeah, that we can actually access. But first here, let's do some hemodynamics and an angiogram to see whether we're actually happy about
Regular J-wire.
the expansion of the stent frame. Recall before we had a diastolic pressure in the aorta of 56, and we got a end-diastolic pressure on 25.
There's something with this pressure set. I don't know. It does not look. I think we will have to change there. There's aspirating some air, but well, the catheter that was also in the start. So now we take out the jail pigtail there by just pushing on the wire.
Do you normally in that position?
You were saying, Ignacio?
Do you normally leave the pigtail in that position? Or move it-
Depending on whether we remember to pull it back, but but it's not a big issue as long as you use a guide wire to bring it out afterwards. Yeah, come a
I
little
agree.
bit
Yeah.
more. You want another pigtail or what?
Well, I think there's something with the pressure set here. We can just change the pressure set.
Okay, so let's see here. We got a diastolic pressure of 46 here. So let's.
Yeah. Yeah.
So it's important to maintain the pigtail in at this stage
Much improved.
before making a decision whether you want to post-dilate, yes or no.
Yeah. So I think we can do an injection here, and we can maybe give 1 mag, and let's see here. We can try to explore. I just try to get the parallax out. We can maybe even go a little bit deeper with the pigtail here.
That's good.
And we're ready here, yeah. So let's do an injection here and see. Let's see a bit more LV. Yeah.
All right, let's go. Perfect.
I don't see any PVL. I don't know what you guys.
This is beautiful.
Yeah, and I think that's what the Acurate Neo 2 actually is. It makes a big difference with regard to a paravalvular leak. And you saw how calcified this valve was.
Yeah.
So next thing, Sabine.
Can you hear me now?
Yeah, we can hear you. Sorry.
Yes.
That's great. So, unfortunately, nobody could hear me during the last minutes. I'm so sorry. So, congratulations. The result is very, very nice. There's actually no PVL at all. Maybe I could ask you if you would use this valve now if you go to more calcified valves with the Neo 2. Would you also use it in bicuspid valves? Or have you done it?
I mean, we have used it in bicuspid valves, but I would also say with the first generation, if it was too much calcium, we would not use it. But I think the impression we got so far with this valve, I think it's a valve which is suitable for even those kind of anatomies. But again, it's important to do a proper pre-dilatation and also sometimes a post-dilatation.
Sure.
Now we're going to show you where we actually got commissural alignment.
First, take out the Sentinel. So removing Sentinel just takes 10 seconds, literally. It's just pulling back this.
Yeah, it's the opposite. Yeah.
Opposite.
So you see, using this embolic protection device doesn't really add a long time to the procedure. It's quite fast. Okay. So we did the valve implantation in what people are saying a cusp overlap view, but it's a right and left cusp which was overlapped. But you can also overlap the right and the non-coronary cusp. And if you do that, you're going to have the left main taking off on the straight right side of the screen. So we're now going to that projection, to the still a cusp overlap view, but not right and left, but right and non-coronary cusp. So you see the C-arm is now moved from an REO caudal to an LAO cranial projection. And as I said before, in this projection, you see now you have one post on the far left side and the 2 other posts overlapping on the right side. So it's promising here. Mm-hmm. And let's just demonstrate that we can actually access the coronary arteries here. So we're just going up with a standard Judkin left here. And hopefully can show that it's quite easy. So of course we need to get outside the leaflets of this valve, as Ole is doing here, coming down, and
so
then
you want to show the
like
coronary access.
Yeah, we just want to show that we actually have commissural alignment as we promise you. Sure. And you see here, how long did it take? 10 seconds to get into that left main. So having this trick, understanding if you're working in a right, left cusp overlap view, it's easy to get commissural alignment. And now we're swifting to a right non-coronary overlap, and we can access the coronary arteries. And again, it is going to be really important in these patients with longer life expectancy to be able to access the coronary arteries in the future. So I think...
Which catheter have you used to access the left main? Which catheter have you used to access the left main?
It was just a standard Judkin left.
Mm-hmm.
Judkin left, okay. Yeah. So I think it's a phenomenal demonstration. This was less than 30 minutes case, including a challenging crossing of the calcified valve and cerebral protection, and I think this was really a very nice technique. And it seems that, and not only everything was under control, but it was very smooth and very predictable in terms of the different stages of the procedure, which I believe is also related not only to your phenomenal expertise, but also to the device itself. I think the two-stage procedure, while the patient is very stable, is definitely an asset during these type of procedures.
So I think now we're just going to close the vessel here, and then we're happy to join you for some discussion if there's any questions about this. So again, this is the Manta system. It comes in two sizes, 14 or 18 French, and since this was a 14 French sheet, we're just going to use this 14 French system here. It again is like a mega size angioseal. So now it's in place here with the plug, and Ole measured, was it 5 centimeter before?
Yep.
We're going to add 2 centimeters to that. So Ole is going to bring it back to, on the ruler here, to it's say 7. And when he's at 7, he's going to deploy here the anchor in the vessel. He's going to pull back and push down here, and then hopefully we have a good sealing here.
Promising.
Yeah. And also.
Do you measure ACT or not at all?
We just gave after the second Sentinel device came out, we gave Protomin as a routine here.
Okay.
Are you happy, Ole?
Yep.
So we take the wire out.
So it looks very nice, yeah.
And there's a scissor here for you. And
I'll keep it until we have checked it. I like it to.
Okay.
And then,
yeah.
That's a nice trick to keep it there
I think we're done.
until the angio.
Yeah. I can just show you here if you can. For those of you who have not used this Manta device, so you can see there's actually, if you look up here, there's a color code. So if there's yellow, you pull. Green, oops, it was not.
We call it the Brazil technique. We see the yellow and the green oblique.
Advantage.
Yeah, yeah. You see here now, green. You have to go up here, and the red, it's too much. You have to.
And then the red.
Yeah. So you should be here on this part, and you can actually even hear it. It's clicking. So I think we only need to check the closure here from the contralateral side, but again, Ran, Sabine, and Ignacio will be more than happy to be part of a discussion about how to treat these patients with longer life expectancy.
Yeah, I think again, as I mentioned, this was a phenomenal demonstration of TAVR in general and the commissural alignment of the Neo2, the new system by Boston Scientific. So my colleagues on the panel, any thoughts, comments, or questions to the operators?
Yes, I would like to discuss maybe. So we had a lot of discussions on commissural alignment in the past when we had valves like the Jena valve, which was designed for commissural alignment. I'm very happy to see now that it's again very easy to use commissural alignment or to adopt it with the valves with the other valves we use. So it looked very easy and very comfortable to do this with the Acurate Neo 2.
We probably need to have wire on here. So they. You see, there's some bleeding here, so I think they're just going to inflate a balloon for a couple of minutes. Yeah, I mean, and back to your comment here, Sabine. You saw this Marco Banzin and the group multi-center study on this Reaccess study.
Yes.
So looking at 300 patients had a coronary cannulation just before the TAVR procedure and just after valve implantation. And actually, in 23 of these patients, 7.7% of the patients, it was impossible to access the coronary arteries. And out of those 23 patients, the 22 was actually treated with the Evolute platform. So for the Evolute platform, it was almost 18% of the patient where the physician could not re-access the coronary arteries. So I think it's stressed that that with these valves, you need to have commercial alignment, and you can do it for most of the valves. You can do it for the, as we said, for the Acurate, for the Portico, and also for the Evolute platform, because these valves have got a marker on the stent frame, so which can be used to make the commercial alignment for deployment.
Yes, and indeed it looked very easy.
Yeah.
I will do that tomorrow in my next case.
We do after tomorrow, so we'll try it as well.
Yeah, I think the case was wonderful. It was also very simple, and I think it's very educative, and probably is the best option for commissural alignment in most of the cases. But I have a few concerns with the strategy. First of all, sometimes, for example, in bicuspid or in abnormal coronary origins, this can be problematic. You can do commissural alignment, but you are not aligned, you are overlapping the ostium. My second concern is that you are doing some torsion of the delivery system within the patient, and if the anatomy is very straight, as in this patient, this works properly. But maybe you can comment if you always have this feeling, or with more tortuous femorals, this is more challenging. And also there is the risk of stroke that here was very nicely prevented, but of course rotating the system within the system can be a problem. I will show later, I think, some slides on an alternative approach for maybe more complex patients or abnormal anatomies.
Yeah. So back to your question, what about bicuspid aortic valve? I think if you have a bicuspid aortic valve, a Sieverts type 1, you often have 3 cusps, so you can somehow do a commercial alignment. And how about when you torque it in, does that, of course, could cause a risk of stroke, of a vascular complication, so you need to be a little bit careful. What we often do, as you saw here, we're going a little bit forward and backwards as we do the torque. I think one good thing is, you know that Medtronic is advocating with the Evolute platform that you have this flush port on the handle, that you turn that to 3 o'clock as you introduce the delivery system. Of course, this is not patient-specific. It just means that for most of the patient, you will be near a commercial alignment. But if you do that with that valve, you need very little adjustment in place. So that's a first start. And I think you can probably figure out the same with the Acurate valve and the Portico valve. How should you introduce it to be close to a commercial alignment, and thereby also reduce how much manipulation you need in the ascending aorta before you cross the valve itself. But again,
regarding tortuous,
yeah, sorry.
Regarding tortuous anatomy, do you find it more challenging? Do you have experience?
Yeah, but I think we have done it for the last, I don't know, 3 or 6 months here routinely with the valve, and it works for most of the patients, and we didn't have any patient-related complications so far, but we need to see it. But again, I mean, 72 years of age, already got pre-existing coronary artery disease. There's a chance that this patient will come back one day with acute coronary syndrome. And if you cannot access these coronary arteries, what are you going to do? I mean, I think we need to take this into consideration. And that's why it's so much different to treat the patient we did in the early part of the program with the TAVI. Patient who had very limited life expectancy, we were happy if the patient survived the procedure and coming out without a stroke and a valve which was functioning. But now it's a different scenario. We need to talk about, when we're talking about this lifetime management of the patient, we have to take these factors in: commercial alignment, durability, conductions abnormality, and so on, which we maybe in the beginning of the program said this is maybe not that important, but it's going to be important if you're going to expand to patient at a younger age and with a longer life expectancy.
Yeah, I agree.
It is certainly a new dialogue, a new discussion in the contemporary TAVI era, when we are treating more and more younger patients at low risk with very prolonged life expectancy. So I fully agree that we have to put it on the table and make our best in order to avoid some, issues that for an 80 or 90-year-old patient was a different aspect. So I think this is very important. Yes, Sabine, you wanted to say something?
I would like to discuss another point. So the Acurate valve is known to have a very low pacemaker rate, maybe the lowest pacemaker rate among the available transcatheter hard valve prostheses. So I still use a venous pacemaker wire during the procedures and leave it in for until the next morning. So what are you doing if you now would encounter AV block in a patient?
I would say, first of all, we have used this LV pacing on the guide wire for most of the patients for the last 2 years. And I would say it's around 90% of the patient who leave the cath lab without a pace lead, and very few patients needs to come back for having a pace lead. If the patient have, let's say, developed third-degree AV block in the cath lab, we're going to put a pace lead in from the jugular vein, and if it's not resolving within a very short time, the patient will receive a permanent pacemaker no matter what we see. I think the patient...
Directly in the cath lab? You would
No. If you could do it in the cath lab, but unfortunately, this is not how the system is trimmed here. It's the rare cases where we can actually put it in here. So often we have to bring the patient back to the ward and can give a permanent pacemaker the next day or the day after.
And if you had...
It's always worth to wait. I think it's always worth to wait 1 or 2 days because it resolves in many patients.
Yeah, but Lars, if you had an LBBB, not AV block, would you place a pacemaker or just watch and wait?
That's a very good question. I mean, I think we don't understand the full impact of a new onset left bundle branch block. We have data showing that it's probably going to be associated with a higher rate of mortality and hospitalization for heart failure. But is a patient at risk for having late high-degree AV block? We don't really know. We, a few years ago, developed an algorithm. So if the patient is in sinus rhythm, the QRS duration is not more than 150 milliseconds, or if the patient is in AFib and the QRS duration is not more than 140 milliseconds, you can safely remove the pace lead in the cath lab. That patient is not going to develop late AV block without a sufficient escape rhythm. And I think that's going to make the decision-making much easier in the cath lab.
I can add for this patient, so the PR is 140 and the QRS is 140.
Yeah, and she's in sinus rhythm, so it's less than 150. So this is unlikely that she's going to develop late high-degree AV block.
How often do you need to post-dilate this valve? And if you had to post-dilate, which balloon have you used?
Well, I would say that's maybe now a little bit different with the Neo 2 also, but I don't know. But up till now, I would say between 20 and 30% we have been post-dilating. And then the size we typically take is a perimeter-derived mean minus 1 millimeter. I always respect that. I never go beyond this size for the post-dilatation.
Yeah. And also, you shouldn't be too high with your balloon in this valve. You should be not higher than the post. Yeah.
With other devices, there has been an increase in the rate of pacemaker when they added this skirt in the ventricular side. Here, the technology is a bit different. Do you think we might face an increase, which is one of the main advantages of Acurate? Are we going to see an increase in the rate of pacemaker in your experience?
Yeah, I mean, we haven't seen that in the CMARC trial. There's a post-marketing clinical follow-up study going on just now with I think it's 200 patients. So let's see whether we got some more data on it. We have done quite a few Acurate Neo 2 cases the last couple of months, and my feeling is that we see more pacemaker rate than we did with the old one. But again, this is a single center experience, and we need to see it in a broader approach with multi-center.
I think the big advantage of the design of this stent is that it has that upper crown, so it prevents from really deep implantations. It keeps it above, that upper crown keeps it just above the calcified leaflets, but that also prevents the stent frame, the bottom of the stent frame, going deep in the LVOT. And it's also a straight part in that LVOT. So we have really a single-digit pacemaker rates here in Copenhagen for our Acurate valves.
Professor Kornowski, if we have the time...
Sorry?
If we have the time, I'd like to show a couple of slides to discuss a little bit more the issue of commissural alignment. Is that
We have few minutes. Yes, we can. If we can load
I
your
don't want
slide,
to.
yes.
Yeah. The only thing is that what they have done is rotating the system, and we have checked that this is predictable how the system will respond. So what we are using is a little variation that can be useful in more challenging anatomies. Maybe, as you can see in the slide, we can predict how many degrees you need to rotate the system before entering the patient. And in the next slide, we can see that actually in the experience now we have reached 20 cases. There is no commissural misalignment, and more importantly below, no coronary overlap in any of the cases. I think a combination of your strategy and this strategy for more challenging cases could be successful. I'd like to know your opinion.
Yeah. Yeah, I think it's great, and I think everything you can use from your pre-procedural CT scan and make a model how you can do it. Again, as I hope you saw, what we are advocating for is patient-specific commissural alignment. Again, back to Medtronic, floss putter in 3 o'clock. This is a start, but it's not patient-specific. And I think what you were showing and what we were showing here during the case is actually to tailor it down to each individual patient.
Do you have any experience with the Acurate Neo valve-in-valve interventions?
I don't recall we have done any so
I've done
far.
once,
No, I've done one, yeah. But I don't see anything why we shouldn't work. Again, it's a self-expanding technology. It's a supinal position of leaflets. It's going to provide you the optimal hemodynamic, particularly in small anatomies.
I would say if you do so, it's for sure feasible. I've done less than a handful, but it's very important that you know how that valve, that surgical valve, is built up. That you look on the Vini Bapat's app, and that you know where the top of that valve is. It's not always very good visible in every on the fluoro. So because it's very critical that what you want is that upper crown just comes above those posts of that surgical valve. And if you do that, you have very good results. But that means look at the app, look how that surgical valve is the design of that valve is.
Yeah, I think I have not done an Acurate Neo case in valve-in-valve, but we have done in 2 cases of homografts where the predominant pathology was aortic regurgitation, and it worked very, very well. So this is also something to be explored in the future. Any final comments, because we are ready to adjourn? I think, again, this was a fantastic case, very nice demonstration, true experts. I think that it was very fluent, and I'm sure the patient will benefit a lot from what we have done. The commissural alignment for future coronary access, I believe it is a very important concept. Certainly we are going to hear more about it, and I think that I'm already tempted to test it in our lab. Any final comments from our panelists?
Congratulations again to a perfect case.
Thanks, Sabine.
Thank you, Sabine.
Yes, this was perfect clinically and from educative point of view as well. Thank you very much.
So I think we have 3 thumbs up here for all of you. And how is the weather in Copenhagen?
Oh, thumbs down, thumbs down.
Well done. Okay,
I'm sure it's better in Tel Aviv.
Okay, thanks a lot. It was a pleasure, and congratulations for a perfect demonstration, and hope to meet face-to-face in the near future with everybody.
Okay,
Thanks, Brian.
Bye-bye.
Thanks, everyone.
Thanks
Bye-bye.
a lot. Bye-bye.
Thanks. Bye-bye.